Hey guys, welcome back to the next session. We're talking about posterior impingement syndrome. We had an opportunity to hear a little bit about posterior impingement syndrome in earlier conversations, but this one's going to be a deep dive into it. Our moderator is going to be Sid Sharma. Mandeep Dhillon, who was going to be with us, is actually traveling for another meeting. Mandeep's a fantastic teacher, but he shared with us a video for his session, so we're going to get that queued up, and then Sid will take over. But thanks again, the entire faculty, and Sid, you can take over after the video. If we can keep the video, guys.
Good morning. I'm going to be sharing my screen and talking to you about the symposium today. Thank you all for joining in today for the Global Foot and Ankle Town Hall on Sports. And today, this part of that is a symposium on posterior ankle impingement in athletes.
Hey, Carolyn.
You know, I have
You
a
guys
great
video
faculty who have joined me today, starting from Rupinder Deol in the UK, Ossama Shazly from Egypt, Panos from Greece, and Siddharth Sharma from India. And overall, there are going to be 5 talks. I'll talk about the incidence, epidemiology, predisposing factors. Siddharth will be talking about the diagnostic issues. Panos will talk about the management of the non-osseous impingement, whereas Ossama will discuss the management of osseous impingement. Rupinder Beer will be talking about when and how to return to sports and what are the factors which influence it. Now, I will be talking about the incidence and epidemiology. Now, what exactly is ankle impingement? If you look at the dictionary meaning, it means to strike, to infringe, to encroach. And that's when tissues get pressed between two hard surfaces or the bones hit each other. And this pinching hurts. So in sports, this pinching around the ankle is fairly common. And you've got sports which talk about football, where pinching is in the front, and cricket, where pinching is in the back. But not all ankle impingements are the same. There can be many variations of the same problem. And today we are going to be talking about the impingement at the back of the ankle. If you look at the literature, it's quite frequent in sports. And if you analyze the literature, you will find that most of the references have been documented in the last 15 years, implying that either there is a lot of interest in this subject or we are understanding more and more. It's not that it has increased because it's been there for many, many years, ever since sports started. So, what really happens? There is a repetitive stress which leads to painful mechanical limitation of the ankle range of motion. This also irritates the synovium and the capsule, and this could be due to secondary smaller injuries like strains of the ankle or positions of the foot in sports or in dancing. And these may ultimately convert into bony spurs. And this is where the pain starts to come into play. You know, all this repetitive stress due to the positioning of the foot in sports or even minor trauma leads to impingement, which leads to pain, inhibition, atrophy, instability, worsens the impingement, and you get a vicious cycle which may have some degree of anatomic predisposition. We'll understand that as we go along. But the key issue is that forced plantar flexion is the problem. Now, the components of posterior ankle impingement could be due to the soft tissue compression, or there could be actually some degree of bony impingement between the tibia and the back of the talus, or sometimes even the top of the calcaneus. Now, there are many factors which are responsible for soft tissue impingement. You have synovitis due to small ligament tears, you have the tendon of the flexor hallucis at the back, and all of this is made worse by bony anatomy, which would predispose to this impingement. You got the talar processes, and you could have ostrigonum in a large percentage of normal human beings. Now, sometimes you get a small protuberance of the posterior malleolus, and sometimes you get a prominent posterior superior tuberosity of the calcaneus. Now, that is unusual, but it will be talked about as we go along in subsequent slides. Now, this is a case series of unusual impingement at the back, and this will happen because of injury to the medial deltoid ligament, which got crushed between the two bones, and this led to a chronic pain and had to be treated appropriately. Now, mostly it is seen in sports where there is excessive plantar flexion. You could go to it in cricket, fast bowlers, ballet dancers, football, etc., etc. In cricket, if you look at all these fast bowlers, the common link is actually that they all had ankle impingement. And there is not so much data out there which is specific to cricket. You must understand that there are 4 or 5 published studies only about posterior ankle impingement, and we were one of the few who talked about this many years ago, and we found that there was a significant incidence of posterior impingement in fast bowlers. Similar data was published from the West Indies by Dr. Man Singh, who looked at 6 fast bowlers who never had pain while they were running, but they only had pain when their front foot landed and they had positioned it in forced plantar flexion. And 5 out of these 6 had an abnormal os trigonum. Now, in bowlers, at the time of heel strike, they land on the front foot and pivot on it. And as the plantar flexion increases, there is pinching. And when they are pushing off to deliver the ball, there is even more pinching. And that happens because of the long delivery slide. Longer the delivery stride, more is the chance of getting impingement in the front foot. You can have it in ballet dancers also. You can have it in other dancers also. And the positioning of the foot is often the problem. In classical ballet, the ideal shape of the foot is called a winged shape when the toes are pointing outward. This is the signature of a first rate ballerina. But this is also the position when there is maximum posterolateral compression. And some of these amateur ballet dancers point the toes inward, which is called sickling. And this relieves the pressure, but this is not considered good in ballet. So, in certain positions, when you have the foot positioned in this demi relief or endpoint positions, you could get problems, and many of these get come to us with dancers tendinitis, which is the tendinitis of the flexor hallucis longus, and this is exacerbated by these extreme positions which these dancers adopt. You must remember that the professionals do much better than the amateur dancers. This is maybe because of their training or whatever the reason. What about football? This is perhaps the commonest sport played all around the world. And then there are so many cases published who have chronic recurrent posterior ankle pain, which is caused by kicking, dribbling, or bouncing. Now, this series looked at 26 cases. 10 out of the 26 were presenting with acute pain. 2 had a tear of the ankle ligaments, 6 had bone marrow edema, and some had flexor hallucis longus tenosynovitis. But all had an os trigonum. The 16 chronic cases had bone marrow edema, and one even had a pseudarthrosis of the lateral talar tubercle. But all again had a prominent os trigonum. And they all had problem when they were kicking the ball because this forces the hind foot into plantar flexion and they developed pain. Remember, they also have a significant amount of synovitis, both of the ankle joint, the subtalar joint, and the flexor hallucis longus tendon also. This is a rugby player who had pain due to a chronic injury where there was immature scarring and exuberant post-traumatic synovitis. So there could be so many causes, but the key point is either a minor injury which sets up a vicious cycle and associated with abnormal positioning of the foot. So what should we do in these high demand athletes? That's going to be talked about in the subsequent lectures, but I would like to tell you all that you have to identify and localize the pain. That's the key point. And then once you do it, you get the appropriate imaging, which will be talked about, Siddharth, in the next talk. But remember, don't let radiology dictate the treatment. Many professional athletes will have spurs and have no symptoms. Many will have accessory bones at the back, like the ostrigonum, and have no symptoms. But even who have mild symptoms, many will respond to rehab. So we need to identify the treatment options. I'm not going into the details, but simple things work in early cases. You can modify activity, brace and taper them, and they do fairly well. But the key point is that many of them will still need surgery. And we have to identify those that will fail conservative treatment. That's the key point which we have to understand. So, the most important point, which many of us often do not emphasize, is that all will not get full relief. These are often high demand sports people. The sport positions the foot in the abnormal, position, and they have some bony or probable cause. And I'll give you an example of Betley, who had surgery on the back of his ankle due to impingement. And when I was in Sri Lanka in 2004, he came to play a test series just after his surgery, and the pain and symptoms recurred. This guy could not play anymore and had to go back. And the reason for this was 2 points. One was inadequate surgical excision, and second was too early return to sports. And that's what Dr. Deol will be talking about today in the last lecture. So, folks, the take home message, this is a common problem in sports. You have to understand that it is often initiated by a minor injury along with repetitive stretch, which leads to soft tissue compression. And certain sports are predisposed, and we just talked about all the sports where this can happen. You must also remember, if the athlete has a bony abnormality, the issue would be worsened. And the non operative treatment has a role when the problem is addressed early. Of course, surgical interventions are key and they will be discussed in the subsequent talks. Thank you so much for your time. I'm going to now stop sharing my screen and I will now stop my.
Okay, so thank you, Dr. Parekh, for giving us the wonderful opportunity to speak on posterior ankle impingement. And after that fabulous talk by Professor Mandeep Dhillon on the epidemiology and overall factors around posterior ankle impingement, I'm going to be speaking on diagnostic issues. I'm Siddharth Sharma. I have no disclosures and no conflicts. This talk is really simple. It will cover the basics of posterior ankle impingement in terms of the clinical features, how do you clinically examine a patient, and the radiological diagnosis. So the subsequent speakers will be covering in depth the management of osseous as well as non-osseous impingement. So let's look at the clinical features very briefly. So when it comes to posterior impingement, the three most important symptoms are pain, pain, and pain, all right? Although many of these athletes will come in with symptoms of clicking, catching, popping. So you have to really put your mind to it when an athlete comes to you with such a history, because this can be the presentation of a plethora of pathologies, but your clinical examination is going to guide you to the radiological investigations. Now, the pain in impingement is more often than not insidious or chronic. There may or may not be an injury episode, and this may then be an acute on chronic presentation. And as is the case with many athletes, it has a waxing and waning course. So where is the pain in posterior impingement? Not very hard to guess. It's at the back of the ankle. But then there are subtle differences. So when you have posteromedial or posterolateral impingement, it will localize to either side of the Achilles tendon, and this is a deep-rooted pain. Whereas the pain from a posterior impingement or an os trigonum or a Stira's process localizes directly to the back of the ankle. Oftentimes, this may be confused with an Achilles pathology. Of course, because this is posterior impingement, the pain gets worse on ankle plantar flexion, and in different sports, you have different ways when it gets exacerbated. So in football, this may be kicking. In cricket, this is when a fast bowler lands on his feet. In runners, it can be when they're running downhill. And whenever you're wearing high heels, so when the ladies are wearing high heels or they're in extremes of plantar flexion, you have exacerbation of pain. So the clinical examination is very, very important to diagnose the pathology and to differentiate it from other things. So in some cases, you can see a swelling on the medial or the lateral side of the posterior ankle. In many cases, you may not have any swelling at all. Now, the double heel rise test is a very useful test in these cases. There is a difficulty to stand on the tiptoes. And then, as you can see on this picture, there is a tendency for the person to invert their foot. Now, Dr. Dhillon already told us about this. In ballerinas, this phenomena is known as sickling, when you're not able to stand up straight on your toes and you tend to stand on the lateral border of the foot to offload your ankle. Now, the tenderness can localize to either side of the Achilles tendon. It is deep, and if there is a tendinosis of the flexor hallucis longus, it localizes to the tendon itself. On movements, you will see that plantar flexion is decreased and painful. As I said earlier, toe walking is painful. The posterior impingement test is very important. So what you do is you have a forced maximum plantar flexion, and in that position, pain is reproduced. If this is posterior medial impingement, you can invert the foot along with a maximum plantar flexion, and it reproduces the pain. Now, resisted movements of the toe can also increase the pain in case of an FHL tendinitis, and this is something that you must assess in each and every case. The posterior heel thrust is another test which has been described. So here, you just give an axial force to the heel while you take it into plantar flexion, and this reproduces the pain. So like I said, this can also be the presentation posterior pain in several other pathologies. So you need to rule out Achilles tendinosis, peroneal tendon disorders, tarsal tunnel syndromes, and even lumbar radiculopathy. So the examination must also focus to rule out all of these conditions. Now, how do you diagnose this? So let's get on to the radiology very quickly. This is the arsenal of investigations which you do, starting from plain radiographs, CT in some of the cases. The gold standard of the diagnosis is, of course, MRI, and then ultrasonography is also important. So these are all the things that you can see on the plain radiographs. Now, what is the os trigonum or the os trigonum syndrome? Now, this is a secondary ossification center of the posterior process. It appears around 7 to 13 years of age and fuses with the body of the talus by 17 years of age. If it fails to fuse, it remains as a secondary ossification center. And how do you differentiate this from a posterior process fracture? So the os is generally smooth. It is single, but it can be also bilateral in about 2 to 5% of the cases. In some of the cases, it can be bipartite or multipartite, in which case it becomes difficult to distinguish from a fracture. And in some cases, this can be connected to the body of the talus by a synchondrosis, which you can pick up on the MRI. Now, the Steedas process is nothing but a long lateral part of the posterior process of the talus. So the lateral process is elongated. Mind you, in many people, this is a physiological finding. So every time you see this on an X-ray, it is not the cause of pain, which is why you have to match your clinical examination to the radiological finding. But the long process can get impinged between the talus and the back of the tibia and produce symptoms. Now, another very important cause for posterior impingement is an increased posterior slope of the tibia. This is also the posterior distal tibial angle. And as you can see on the image on your right, this is a normal posterior distal tibial angle, whereas on the left, but on your right, this is a tibia with an increased downslope. And as you can see, this will predispose to impingement. And this is something that you should evaluate in each and every case. Now, also as a rare finding, you can see prominence of the calcaneal tuberosity, which also becomes a predisposing factor for impingement. So these are all the things that you can see and you should evaluate on plain radiographs. In long-standing impingement, you also start to see loose bodies around the ankle. And in cricketers or in footballers, you will also see combined impingement when you have, evidence of impingement at the front and at the back. So a CT scan is rarely indicated, but this is very important if you want to differentiate an os from a fracture. And in this case of a footballer, you can clearly see the fracture line. The edges are serrated. They are not smooth as compared to the fracture. And then you have this terminology around posterior process fractures. So a fracture of the posterior lateral process is known as the Shepherd's fracture, whereas that of the medial tubercle is known as a Siddell's fracture. Now, the MRI is the mainstay of imaging, and Dr. Panos and Dr. Ossama will also be talking of this in their subsequent presentations. But let me just get through some of the common findings. Now, this is a 22-year-old male cricketer who presented to us with posterior impingement. And as you can see here, there is a lot of fluid at the back of the ankle. This is a T2 weighted image, a mid-sagittal section. And as you can see, there is a lot of fluid. You can also see that they have a long Steer's process. You can also see edema within the Steer's process itself. And on the axial section, again, you can see the edema at the back. This in the center is the tendon of the flexor hallucis longus and surrounding edema. And that's the posterior talofibular ligament. You can see a signal change and thickness of the PTFL, which is also one of the characteristics of a posterior lateral impingement. So the same case, and then moving to more medial sagittal section, you can see that there is a thickening of the flexor hallucis longus tendon and edema around the tendon itself. You can also see edema in the posterior medial body of the talus. So these are all hallmark findings of a posterior impingement. From another case, you can see that there is a FHL tendinosis. So there is thickening of the FHL tendon, edema around the tendon, and thickening of the tendon itself. So this is an amateur runner who came with pain at the back of the ankle. Clinical tests were positive, and you can see that this is the PTFL. The fibers are wavy, they're thickened, and there is signal change within those fibers suggesting a posterior lateral impingement. Now, this is the posterior medial impingement. And as you can see, these are fibers of the deep deltoid. There is thickening, waviness, and signal change, and there is an associated osteochondral lesion of the talus. Now, ultrasonography is very, very important in these cases. I'm going to touch on it very briefly. This is so important because this gives you a dynamic assessment. Now, mind you, many centers also have dynamic MRIs, but not available in every center. But ultrasound is one modality where it lets you visualize the things in real time. So you can pick up the fluid, tendinosis, thickening, and you can also use it for your guided injections, which can be diagnostic or therapeutic. So the take-home points from this very brief presentation is that a thorough history and clinical examination is a must for all of your athletes presenting with possible impingement, because all findings that you see on the X-rays may not be of clinical relevance. And it's also important to know what to look for before you actually start the imaging. Be aware of all the normal variants, and then look specifically for osseous and non-osseous forms of impingement because they are going to guide the treatment. Thank you. So with this, I'm going to hand over the stage to Dr. Panos, who will be talking to us about non-osseous impingement. Over to you, Dr. Panos.
Thank you very much. Can you see my screen?
Yes.
You hear me?
Yes.
Excellent. So, I'm Panos Symeonidis. I'm practicing in Greece, Thessaloniki. Thank you for the honorable invitation in this great event. The most simplistic way to assess the bony impingement is to differentiate between the Stieda process, as Dr. Sharma already mentioned, which is an elongated posterior talar process, and more precisely the lateral talar process, the osteogonum that we're going to talk more about, and a fracture of either the two, that is the Shepherd's fracture. Sometimes you also have some malunited fractures. We're not going to get into that. These are some radiological images. And of course, there is a significant overlap on all of these conditions. So the osteogonum is much more common than we used to think. It becomes symptomatic after overuse or trauma. But the severity of symptoms does not seem to relate to the size of the ostragonum. And more importantly, expanding of what Dr. Sharma said, the mere presence of the ostragonum does not constitute the diagnosis of the impingement. This is a young soccer player with this ostragonum evident on CT, MRI, but if we move a few slices medially, this is the true cause of his pain. He has a talar OCD, a detached one. So you really need to rely on the clinical examination as the previous speaker outlined. And also, the clinical examination might not differentiate between bony and soft tissue impingement, and they don't always need to because there is usually an overlap. This is a soccer player with an ostragonum, sudden hindfoot pain, and you can appreciate in those axial images, apart from the ostragonum, there is a bulky, a chunky flexor hallucis longus that causes also, it's part of the pathology. And you need to really familiarize yourselves with the MRI and the different sequences. These are two cases that seem quite similar. We have the big ostragonum, but if we move to the other sequences, the case on the left, you also appreciate there is an element of anterior impingement apart from the posterior fluid. Dynamic imaging, as already mentioned, we use the ultrasound, but also those dynamic X-rays on plantar flexion. This young dancer, you see when she was in the M-point position, the space between the posterior tibia and calcaneus narrows, and this rather small ostragonum becomes quite symptomatic. I think that was not mentioned. We sometimes use bone scan or PET-CT when we have access to it, and you can identify those warm spots in the bony impingement. Not all of these spots are bone impingement. We had a case that we published some time ago. We had the Stieda process, but it was actually an osteoma. So under guidance, under ultrasound or C-arm, you can have injectables both for diagnosis, but also for treatment. As part of the conservative management, there is not much evidence on which is superior, but use the imaging in order to protect the neurovascular bundle that is quite near. With going to the operative management, what about mini open? Surely you can do that, and there are older and newer studies that show good results. That's an older case from our fellowship, but we would say that there is accumulating evidence nowadays for the arthroscopic treatment. Back in 2016, we have more than 250 cases, and there is level 3 to 5 evidence. And it does become a standard. It becomes a treatment of choice. And yes, you need to attend specific courses. There is a learning curve, but it's minimally invasive and probably it leads to a quicker recovery. So most of us owe some gratitude to Prof. Nick van Dijk, not only because he described the method back in 2000, but he has taught hundreds of surgeons around the world of how to do it safely and effectively. And essentially, this is what we do also: prone position the patient, two portal technique, starting with a lateral portal, aiming to the first web space with a trocar, and then introducing a blunt Kelly, creating a space and trying to identify with debridement the ostragonum and the flexor hallucis longus. You need to be familiar with the details of the local anatomy. These are some amazing specimens from the early diseased Pau-Golano, all those ligaments and their variations there. And this is the good scenario where you have a small ostragonum with just a fibrous bridge, and you can easily release it with the help of some arthroscopic scissors. This is more the exception than the rule. Usually what you're facing, and this is another case, is a quite fibrotic environment where you need to introduce something like a cope or an elevator, identify the subtalar joint and try to delineate the borders of your ostragonum, and then gradually working with your body for the subtalar range of motion, feel the bridge and debride and try to cut if it is fibrous with scissors, or if it is an osseous or cartilaginous bridge with a combination with osteotomes. This is usually what you're facing. So you're working with a shaver away from the flexor hallucis longus, and gently trying to work around the ostrigonum by clearing all the soft tissue there. And as you move along with experience, this is another case, you realize that you don't need to debride everything around it. It creates a very nice picture, but the more you debride, you have more swelling postoperatively and a longer rehabilitation. So you tend to follow the rule less is more. You just try to delineate around the ostrigonum and remove only what is necessary. Not all of the fat pad there is part of the pathology. And also switch different shavers. This is the same case where we switch to a 2.5 shaver, trying to identify all the borders around the ostrigonum, again, working against the FHL and protecting its borders. And essentially, in the end, you may end up with only a fibrous bridge with from some of the ligaments, and then you can cut it with arthroscopic scissors. But more commonly, you also have a fibrotic, which is cartilaginous bridge with the rest of the talus, and then you need to introduce actual osteotomes, either straight or small osteotomes, and work your way by gently pushing and tapping, trying to identify the border of the ostrigonum. You don't want to go too near the ankle joint in order to avoid injuring the cartilage there. And with patience and feeling where the border of the ostrigonum is, in the end, you can release the ostrigonum as a whole and block, and that leaves the posterior aspect of the talus exposed with some cancellous bone there. And this is what you end up with. This is the flexor hallucis longus, and that's the cancellous bone that is exposed. Postoperatively, if you remove it at one piece, that's even better. But if you move it piece by piece, it doesn't really seem to make a difference. What makes a difference is you need to identify the rest of the issues, as Dr. Ossama will show. This is a flexor hallucis longus that a low riding muscle belly. By moving the big toe, you see how it squeezes in the canal. So removing the ostrigonum is not the whole operation. You need to identify all the rest reasons. This is our usual after treatment. And as James Calder also pointed out, and Rupi would come to tell us more about it, the bone impingement has a slower recovery than the soft tissue one. This seems to be the trend, and it makes sense. And finally, what about the stieda process? That's more difficult technically because you don't have a clear border. You need to work vertically with your osteotome and create actually the border between the stieda process and the rest of the healthy talus. And there is a risk of going too far in the ankle joint. You need to work very gently, and even with those small taps, by releasing that stieda process, you will still have a large area of cancellous bone in the bridge that is exposed. And that led us also to the assumption that probably they will take longer to recover. We tested this hypothesis in a small study where we had a group of patients of ostrigonum and the other with stieda. And indeed, in 6 months, the ostrigonum patients fared better, had better results. This was not significant in the 1 year, but I suspect this is because of our small numbers. If we had a bigger series, that would also show a difference there. Complications can occur, and with more experience, you have less complications, of course. But what was interesting is that some athletes report a sense of instability after we removed the ostrigonum, and they didn't have this instability. There seems to be a connection between impingement and instability, and Peter and their colleagues first noted that, Peter Tog, and we don't really know what causes what. Is it a symptomatic instability that makes the bone impingement symptomatic, or when we remove, is it revealed, does it reveal an instability? So we still have a lot to learn about the posterior impingement. My take-home messages is that you need to be able to identify the cause or the causes of the pain and treat them one by one, and really master your clinical skills and utilize all the imaging studies you have in hand, dynamic and static, because there is usually an overlap with the soft tissue impingement, as the next speaker will show. And with regards to conservative management, injectables seem to work. We need more evidence on that. And for the operative, probably the gold standard is the arthroscopic excision. And my last message, this was a great session, and thanks to Selene, Parekh. This is what we can do when we all work together. And hopefully this is how the whole world will operate soon in these turbulent times. Thank you very much.
Thank you, Dr. Panos. That was an excellent talk and very comprehensive. So can I now invite Dr. Ossama to present his talk on osseous impingement?
Okay, do you see my presentation right now or not yet?
Yes.
I'm sorry.
We can't see it now. Yeah.
Okay, just a moment. Okay, is it seen now?
Yes. Can you go to
Okay,
the full
thank you.
screen, please? Yes.
Okay, thank you, Sharma. Thank you, Mandeep, and thanks, Selene, for organization. And thanks, Panos, for giving us a pavement for my lecture. I think when we talk about posterior ankle impingement, we have to think on how to diagnose this and how to differentiate, because as shown by Panos, we may have different pathology which causes pain, and we find in MRI or CT scan some findings which may direct us to impingement. So diagnosis is crucial. We heard about diagnosis from Sharma, and we knew just now that we have two forms, osseous impingement with Schneider process or ostrigonal, and we have non-osseous impingement which caused by soft tissue. What are the causes of non-osseous impingement which may cause posterior ankle pain? We can have tenosynovitis of tendons like flexor hallucis longus tendon or FDL or tibialis posterior even, which causes synovitis and pain in the posteromedial aspects of the ankle. We may have some deep deltoid ligament injury or pathology, which causes soft tissue impingement in the posteromedial corner. And this is common in athletes after a sprained ankle, and it's mixed with posterior ostrigonum syndromes and tibialis posterior synovitis. We can diagnose it with MRI and other modalities as we have seen. Also, we may have some synovial pathology, like some synovial tumors. We may have chondromatosis, and we may have nerve lesions like schwannomas of the nerve, posterior nerve, and we may have some rare causes like accessory muscles, like flexor digitorum accessorius or flexor peroneal accessory bone. Diagnosis of this condition relies on MRI and ultrasound, as we had said, and we will go through some cases of this soft tissue impingement. The first case is for stenosing tenosynovitis, as we had heard just now, that the flexor hallucis longus passes between the medial and lateral tubercles of the posterior process of talus in a tunnel, and there is something like a pulley which holds the flexor hallucis longus tendon between these two tubercles. Impingement happens when we have frequent plantar flexion or repetitive trauma, which causes hypertrophy and thickening in the tendon pulley, and this causes soft tissue impingement. Sometimes if we have ostrigonal or long Schneider process like this will cause friction. The condition happens, as we heard, in ballet dancers. This is why called ballet dancer syndromes, and usually in this musculotendinous junction. We have some other sports which can cause this. One of them is monofin swimming or repetitive plantar flexion in some swimmers, like this monofin swimming. Also for Muslims country, this position in prayer, in sitting position, in this position is an impinging position. This is a common complaint in Muslim countries, that we have pain during prayer because this position makes it an impinging position. We have to suspect in the patient when he complains of retromalleolar deep pain or he have painful plantar flexion, and we had seen the signs described by Sharma, forced plantar flexion, also moving the toe against resistance. This will cause all pain. MRI is crucial for diagnosis of soft tissue impingement. Usually we don't see anything in the X-ray unless there is pony prominence or pony impingement, but MRI is crucial. I don't rely on ultrasound for diagnosis of deep tendons impingement. It's maybe easy to use ultrasound in Achilles tendon, in retrocalcanean bursitis, but for flexor tendons deep, I don't like using ultrasound for diagnosis. You can see in the sheath fluid around the tendon as here. Treatment, as mentioned by Panos, medical treatment, physical therapy, activity modification, or ultrasound injection, but endoscopy is a gold standard technique for a release of soft tissue around the tendon. A case like this with posterior impingement caused by flexor hallucis longus tendon, we use a standard Porter's described by Van Dyke. You have to be patient a little bit in debriding the retrocalcaneus spares. The landmark you have to look for is the flexor hallucis longus tendon. You can localize it by moving the big toe, and then you start removing the bone bands around the tendon until complete release. One of the technical tips, don't remove the medial wall of the sheath, because after this medial wall, you will find directly the neurovascular bundle. So I never remove the medial wall of the sheath. I remove the posterior, the lateral, and I release down to the pulley in the tunnel of the flexor hallucis longus tendon. Another kind of soft tissue impingement is impingement by deltoid ligament injury, which is common also in athletes and after sprained ankle. We can diagnose it with MRI when we find some scarring tissue present in the medial gutter in the deep deltoid with intact most of the deltoid ligament, only some scarring and T2 weighted images signal changes here in the medial gutter. We can find also posteromedial ankle pain, and when you look in the MRI, you can find a lot of scarring here in the posterior space. This is different from flexor hallucis longus tendon tenosynovitis, in which the tendon sheath is filled with fluid. Here it's away from the tendon sheath itself. In this case, we make the same. We can do it through anterior ankle arthroscopy, but we can do it also in posterior. In order not to cross the flexor hallucis longus tendon, you need to open the ankle joint posteriorly by removing of parts of the long intermalleolar ligament. Then you go to the medial gutter and you start cleaning the medial gutter until it's completely clear and free. Another cause of posterior impingement is synovial pathology. Sometimes you have multiple loose bodies like chondromatosis, which comes anteriorly and posteriorly, and you can remove it with arthroscopy, like this case with multiple chondromatosis in the synovium causing posterior ankle pain. And when we removed, we find these multiple loose bodies causing impingement. We check here the tunnel of the flexor hallucis longus tendon, and it's clear. Some tumorous condition may be also diagnosed here, and this is a case of pigmented volnodular disease causing posterior ankle pain, and we made MRI and we'll find it's pigmented volnodular disease. This case for Xavier Oliva from Barcelona, and you can find here the synovial thickening posteriorly. you have to debride it completely in the posterior part. And this, after complete resection, it causes complete relief of pain of the patient after release of this pigmented volvinodular here. A take-home message: posterior non-osseous impingement causes posterior ankle pain. Diagnosis requires suspicion. MRI is essential for diagnosis, and I agree with Panos that arthroscopy technique is a gold standard technique for all impingement syndromes in the ankle. Thank you very much.
Thank you, Dr. Ossama, for that wonderful talk, and it covered all the important aspects of the soft tissue impingement. Moving on to the next speaker, we have Dr. Rupinder Deol, who will be talking to us about return to sports after impingement. Over to you.
Thank you, Sid. Good afternoon from London, England here. Good morning to you all in North America, wherever everybody is. Thank you, Mandeep, and thank you to Selene to speak about return to sports, timing, rehab, and related factors for this session. I've been watching it so far. It's been a fantastic session. I don't know how you've kept awake for this long, Selene. No conflicts to declare for this talk. Quick overview. I know I'm the last speaker and we want to get some questions in. I'm going to run through the pathology, a bit about the evidence of sports impacted and sports implicated with posterior ankle impingement, a bit on timing, related factors, touch on rehabilitation. So, as we've heard in the previous talks, posterior ankle impingement describes a group of pathologies that's characterized by pain with plantar flexion that can be worse with loading and can lead to restricted movement. And as we've heard the two distinct categories of osseous versus soft tissue, there's often a combination of pathologies. And an osseous component is usually present in near 81% for the causes that we've heard, and soft tissue in 35%. And FHL pathology, again, as we've just heard, is more common in the dancers rather than the soccer players. So what about the literature on sports and posterior ankle impingement? Well, Bill Ribbons and his team in 2015 did probably one of the most comprehensive reviews on sports posterior impingement and looked at all the literature to date at that stage. And the majority were level 4 and 5 studies. And they actually looked at 47 papers and only 7 had prospective data. And they were the newer papers on arthroscopic techniques. And the outcome measures didn't have any real standardization. What they also noticed was that the studies from the 90s and the early 2000s focused more on arthroscopic factors. And since then, as we've heard, we've had more arthroscopic changes. So we're almost comparing different eras of surgery in that time. What did they find about the implication of sports? Well, ballerina's ankle, dance and ballet in particular, was the commonest, 62%. And then far less significantly in the literature, soccer, and then a host of other sports. However, I think there might be some bias in reporting here because we heard a fantastic session this morning on cricket and particularly fast bowlers with their forefoot going into a hyperplantar flexion and loading, getting posterior ankle impingement. But actually there's relative scarcity in the literature. I think there's a paper from Mansingh in the West Indies with a small series, but not much more. So whilst we as foot and ankle surgeons would appreciate that cricket is and certainly fast bowlers and cricket, there is going to be an instance of posterior ankle impingement, I'm not sure that that's reflected in the literature as yet. So timing to sports. Well, this review series found that soccer had a significantly faster return than both ballet and jump athletes. And you could be as low as 6.6 weeks with arthroscopic techniques, all the way up to 15.6 weeks with open in athletics. And this is the evidence base behind the finding. And clearly dance has the largest number of studies included. And I think these are more historic and they're more open, as you can see there. one of the reasons in dancers that you may have a longer rehabilitation period, certainly in the adolescents that are treated, such as in Andy Roach's paper, there's generally a bit more caution for safety in return to play and sport. So there are a number of confounding variables that we have to appreciate. There's which surgical procedure has been done, which regime has been used, the technical demands, organizational issues, what financial drivers. So there are a number of other factors that we haven't really been able to quantify properly in the literature. But what does the literature tell us? Well, Panos said maybe arthroscopic is a faster return to open. I think the literature says it is. And I think we've got enough to say that the arthroscopic techniques do get back quicker. The Ribbons paper said you've got 8.9 versus 14, and Guo almost 50% of the time with arthroscopic rather than open. And Georgianis in 2017 did a level 2 RCT that showed there's a significant improvement in return to sport and training if you go arthroscopically. What about elite versus amateur? Well, back in the mid-90s, Hamilton said that there were better results for professional athletes rather than amateur dancers. But the elite athletes are a bit of a double-edged sword. While the expectation is there, because you've got the money, you've got the support, you have the resources, the facilities, the time, the incentives, they're also less tolerant of a drop in performance level. And again, we heard this morning, the difference between playing in the Premier League compared to the Championship, the financial differences and everything that goes with that. So the evidence here is lacking. Whilst we would like to think that they do better, we can't really say that from the literature. What about, do bony get back quicker than soft tissue? Again, equivocal. Panos touched on James Calder's paper of soccer players in 2010 returning sooner. But prior to that, we've got the work from Hamilton in the mid-90s and Van Dijk, who proposed that actually bony could get back quicker. And what about trauma versus overuse? Well, one thing that seems to be quite clear, whether it's open or arthroscopic, is that overuse injuries generally do better than traumatic. And I think one of the reasons for that is we've touched on a few of the conditions in terms of bony and soft tissue, but there are a lot of other causes of posterior ankle impingement. And certainly with the stuck down posterior malleolar fracture, the missed syndesmotic fracture, there are a number of other issues, and they don't seem to do as well in terms of getting back to sport. And lastly, rehabilitation. There's no single evidence-based rehabilitation in the literature. And this seems to be sport and pathology dependent. Conservatively, there's a lot written about rest, putting in boots, splint, anti-inflammatories, cortisone injections. And generally after surgery, and particularly after arthroscopic surgery, early motion and early weight bearing seems to be key to get players back, but it's lacking strong evidence. And I think the sport specific is the key, where the future is in terms of looking at things. We heard this morning again that the hard, flat mud surface at the side of the road is actually the surface that many thousands of Indians will play on to play their cricket. So, we have to look at different surfaces, different footwear, cleat design, and all these things. And I think at present, there's a lot we don't know about that. So in summary, what do we know? Well, the pathology is often mixed. It's bony and soft tissue, and the proportion of that can vary. Dance and soccer are the most commonly reported sports, but we think there are others out there that probably need to raise their head a bit more in the literature. You get good surgical outcomes, both open and arthroscopic, but the arthroscopy, patients treated with arthroscopy generally get back to sports quicker, and overuse symptoms do better than trauma. What we don't know is, are the elite athletes getting back quicker than the amateur ones? Do the bony do better than soft tissue? And a really key point at the end, what is the ideal rehabilitation for these patients? Thank you.
Thank you, Dr. Rupinder. So I've been informed that we have about 5 minutes left. And may I ask Dr. Selene if there are any questions?
As of right now, no questions from the attendees.
Okay. So my question to all the panelists here, and Dr. Panos, you talked about nuclear medicine scans for posterior impingement. So my question to all four of you, how many of you use nuclear medicine scans as a diagnostic workup for your posterior impingements?
I would say it's the exception rather than the rule. It's just one other thing on our tool. I don't routinely use those, but as we showed in that case with the osteodysteoma, they can be of some benefit in cases, especially the PET-CT, not so much the bone scan. That's the exception.
Yes, likewise. I don't use it routinely. And in fact, I don't think I have in a case of posterior impingement, but I think there probably is that rare case that could benefit from it. I do think perhaps standing CT seems to be the rage, and that may add, certainly Nick Van Dyke, when I did his course many years ago, was all about CT more than MRI, the focus. And I wonder whether we're going to see the evolution of that into standing CT.
So one thing that is really coming up now is functional imaging. So you have sodium fluoride PET imaging. So this is something which is still not routinely available in my center. So the scan that you talked of, Dr. Panos, is that a 3-phase bone scan, which you use routinely for orthopedics?
Yeah. This is the standard. The other one is hardly accessible. It's for tumor cases and it's quite pricey.
Okay.
For me, I don't use bone scan. I have limited use of bone scan in my practice in general. I think MRI gives better diagnosis for me. It can replace bone scan in many diagnoses. Also, surprisingly, in my country, in Cairo, it's easy to make bone scan or CT scan for the patient, but nuclear has limited centers doing this imaging modality. I think not all centers doing it, but it's easy to find MRI in different centers in Egypt. So I don't use bone scan. I think it doesn't add value like MRI. It has a lot of differential diagnosis, which causes the same hotspot here. So what's the cause? Okay, it's hotspot. So why there is hotspot? So I need MRI usually after bone scan. So I don't use it in my practice usually.
Excellent.
Thank you.
Sid, thank you for moderating. You guys, thanks for a fantastic hour of posterior impingement syndrome. You know, I think in a lot of places it's still a little bit of a black box. So it's nice to get so much insight from all of you guys and Pearl. So I appreciate that. We are going to come back in a minute for the next session. Thanks, guys.
Thank you.
Okay.
Thank you. Bye.
Yeah.